Hello, I'm Dr. Tom Lomax. This is a short video about return to school during the COVID-19 outbreak. First of all, a quick waiver. I'm a medical doctor, I'm a GP, but this presentation does not constitute provision of individual medical care. So if you have individual health concerns or you need advice about individual decisions, please consult with your regular doctor. Okay, so in my medical practice, I look after quite a lot of parents with young children or older children and a certain number of teachers. And of course, I've got children myself. So these questions are things that have really crossed all of our minds recently. First of all, and most importantly, how dangerous is COVID-19 for children? But also, what's the risk of COVID-19 spreading in schools, particularly now as they start to open up? And I guess as a healthcare provider, I'm particularly interested in what the risk is of COVID-19 spreading within schools and then spreading to the wider community. So let's look at Japan first of all. In Japan, as of yesterday, there had been slightly less than 17,000 recorded cases of COVID-19, and of those, slightly under 700 occurred in people under 20. That's about 4%. And as of now, there have been no deaths in children in Japan. There have been a very small number of deaths in younger people. I think the youngest person to have died of COVID in Japan is 28. This is broadly similar to other countries. In countries where there have been much larger outbreaks of COVID-19, in the US, where there's been more than 1 million cases, for example, there have been a small number of deaths in the pediatric age group, unfortunately. Okay, so one of the things that a lot of people come to me with is that they don't really feel confident about the numbers that are put out by the Japanese government. And particularly, that's because earlier on this year, testing was very limited in Japan. And people with milder symptoms or few symptoms, by and large, were not tested. So quite a lot of people say, well, maybe there were a lot more cases in Japan, it's just they weren't ever picked up. And I think if you want to get an idea as to whether there might be a hidden underlying number of cases in young children particularly, it's good to look at an environment where a lot more testing was done. So I think the best example in the literature at the moment is probably Iceland. They had very extensive testing, quite a small country with a population of 300,000. But in Iceland, anyone who travelled outside of Iceland was tested. Anyone with a contact history, of course, with a COVID-19 case was tested, and anyone with any symptoms was tested. So in Iceland, you didn't have to have a high fever for 4 days, or you didn't have to have like a pneumonia on a chest x-ray or a CT. Even if you just had mild cold symptoms, you would get a test. And additionally, they had open invitation testing, which basically means anyone can get tested regardless of contact history or symptoms. People can get tested just if they're concerned. And additionally, the Icelandic government decided to randomly sample the population. So just to send out invitations by text message on people's phones and suggest they come in and get tested. So they did a lot of testing. Let's compare. So in Iceland, in March and in the first half of April, 6% of the whole population was tested. If you look at Japan in the same period, less than 0.2%. So in Iceland, you were more than 20 times more likely to get tested. So of these tests, in Iceland, in the group of people who were targeted, that's people with a travel history, with symptoms or with contact with COVID-19, about 14% of people tested positive. And in the random population test, they found that slightly less than 1% of the population was infected. Okay, so inside those random tests, that's people who were tested without any symptoms, contact history or travel history, 848 children up to age 10 were tested. And out of those 848 children, none of them tested positive. Now, looking at the wider population, there was quite a big skew on how likely you were to test positive if you were just a random population test against your age. So actually, it was people aged 40 to 50 who were most likely to test positive at about 1.5%. Young children, no positives, and children aged 10 to 20, about 0.3% of tests were positive. So it seems that children just didn't really catch COVID-19 in Iceland when they were tested. Okay, that's Iceland. It's a small country and it's a long way away. I mean, can we extrapolate their experience to what's happened in Japan? Well, let's look at some other countries where there's been a lot of high quality data released. So first of all, South Korea. So in South Korea, recently an account of the first 7,755 cases has been published. And again, that shows there were a very small number of cases. This is people who were actually infected and presented for medical care. About 1% of all cases were in under 10s and about 5% in age 10 to 20. So, broadly similar to other countries. And then I think there's another very good study that's worth looking at, this time in Italy. So this is Vo. It's a town in North Italy. It's close to Venice. I think as we're all aware, in February and the beginning of March, Italy had the most high-profile and relatively severe outbreak, and that was particularly concentrated in the north. So that's Vo. Vo had a lot of cases and quite early on, and in response to that, 70% of the entire population of the town was tested, and over 2.5% of people, this is just random testing of people who weren't sick, this is not people presenting to hospital, 2.6% of the whole population was infected. But again, consistent with the data in Iceland, there was not a single case in anyone under 10. So, conclusion from looking at the numbers from a number of different countries, and particularly the high quality data that's been published from Iceland and from Italy, best current evidence at the moment suggests that when you do test high numbers of children, which has never happened in Japan, even if you're testing in areas where quite a lot of adults are being infected, you tend to find very few cases. So we know that children can obviously get COVID-19, and we know that sometimes they can become asymptomatic carriers. And we know that sometimes happens in adults as well. But in children, this seems to be quite rare. It seems to be quite unusual. So given that we're not seeing very many COVID cases in children, what's the particular interest and focus on schools? And for example, why did Japan close schools rather early on? If you think back to February, Japan closed all of the schools in Tokyo before any businesses or any wider parts of the economy were shut down. There must be some reason for that. That wasn't just done randomly. And the reason for that is this virus. So this is a different virus. This is influenza, actually. And really, when we were dealing with a new pathogen, all we really knew about COVID-19 is that it was a respiratory infection. So we made a sort of assumption that it would behave like other respiratory infections. We've known for quite a long time that influenza tends to propagate in schools. And research done over 15 years ago has shown that if there's a preschooler in your house, you are 80% more likely to catch influenza every season. Okay, that's not the preschooler, that's you as an adult living with a preschooler compared to an adult who's living in a household without young children. We also know that preschoolers who get influenza for whatever reason, if it's they're more tactile or if they just shed more virus, they're 85% more likely to spread influenza to people they live with than an adult with influenza. So if an infected preschooler comes into your house, you're at nearly twice as much risk as if an infected adult comes into your house. So what was the response to this? We know that influenza seems to spread more quickly and well through young children, and quite often we then see those influenza epidemics spreading into the wider community. So what do we do? Well, influenza is not a trivial disease. It's not just a bad cold. It kills tens of thousands of people annually in Japan and equivalent numbers in other countries. A lot of these people will be end-of-life, comorbidity, elderly, but actually it also does rarely kill young, healthy people. And we've shown through some quite high-quality research that if we vaccinate children, it doesn't only protect the children, it protects the wider community. And vaccination programs that target children prevent 0.7 influenza cases per influenza vaccine administered. That's not just in the children, that's also factoring in the reduction in disease in the wider community. And we also now know that every 1,000 influenza vaccines that we give in a child-centered program will save 2 lives. That's not the children's lives, it's the lives in the wider community. So influenza vaccine saves lives, and not just the lives of the people who receive the vaccine. We also know that in bad influenza seasons, it may be necessary to close classes or sometimes even entire schools. And that is, of course, partly to protect the children, but it's also to prevent the spread of influenza again into the wider community. So, what about COVID-19, and will it behave in the same way as influenza? Well, it seems that it doesn't, but let's look at that in more detail. So, the best quality data we've got at the moment about spread of influenza in schools probably comes from New South Wales in Australia. So we've moved from Iceland to Italy, and now we're looking at Australia. So Australia had a broadly similar experience with COVID-19 to Japan, in that 4% of the cases again occurred in children. Although it's interesting to note that in New South Wales, nearly a quarter of the population are children. The rate of infection is far below that. So unlike Japan, schools in New South Wales were kept open in March and April, although there were quite a lot of modifications put in place to how children were allowed to behave in school. Well, what happened as a result? Okay, so during March and April, 18 people infected with COVID, that's people who picked up COVID infections outside of school, went into school and were then found to have become infected. That's 9 staff members and 9 students. Australia has a very good contact tracing program, and that was applied to the schools. So anyone who'd had close contact with those 18 people was identified, and in this instance, close contact was defined as 15 minutes of conversation or 2 hours spent in the same room. So, I mean, a teacher teaching a class for 2 hours, then the whole class would be classified as close contact. And from those 18 index cases, tracing identified 863 close contacts. So, there's a lot of close contact occurring in schools, as there would be in a business, for example, a company or a restaurant. All of those 863 close contacts were followed up. So they were given detailed symptom questionnaires. They had PCR testing, sometimes not only if they were sick, even just done to rule out infection. And then later on, antibody tests were performed. So what did that show? Let's look at secondary schools first of all. So New South Wales secondary schools, here they are. So across the whole territory, 10 schools were identified where a COVID case had gone into the school, and a total of 12 index cases. So some of the schools, you can see each beige box there is a different school. Some of those schools had more than one person with COVID-19 go into the school, and most only had one. The blue circles are teachers and the green circles are students. So for example, in the center row down at the bottom, we can see these 2 schools both had 1 infected staff member coming in, and in both of these 2 schools at the bottom here, there were 10 index contacts, but on the left side you'll see there were more than 200. Okay, so of those close contacts, if you add them up across the 10 schools, there were nearly 700, 695 in total. Only 1 infection occurred within school. That's the red dot on the left side at the far top. So a lot of close contact identified, a lot of tracing and a lot of testing, but actually only 1 infection. That's secondary schools. Let's have a look at primary now. Primary schools, the situation's broadly the same. Again, there were a smaller number of students, 5 schools and 6 students going into them with infection, and relatively less close contact, 168 close contacts identified. But again, only 1 infection. So again, you can see 1 red circle there. So let's summarize that. Summary is, from 18 index patients going into all these different schools, and from the 863 close contacts that ensued, there were a total of 2 infections. And those infections were both students, so no teachers were infected. The summary that the authors of this report give is that spread of this virus, spread of SARS-CoV-2 within schools in New South Wales has been very limited. SARS-CoV-2 spreads considerably less well in schools than other respiratory viruses, for example, influenza, which we looked at earlier. And they further go on to conclude that children are not the primary driver of COVID-19 spread in the wider community. COVID-19 rather appears to be a disease that spread from adults to adults. So that sounds rather positive, and I guess if you were an optimist, you might look at that and say, well, really this disease is nothing to do with children. But I'm afraid that's not the case. This does not mean that we can go back to 2019. So this is the SARS-CoV-2 virus this time. We definitely can't just go back to the way things were before, unfortunately. New South Wales schools did stay open, but they made quite a lot of modifications to limit the spread of infection. For example, they banned contact sports and they seriously limited the movement of people into the schools. They restricted parents coming into schools quite significantly. So very little infection, but that's in the context of quite a lot of measures put in place to reduce the spread of infection. The other thing to say is this is still relatively early days. This is preliminary data. This is a new disease that we've only been dealing with for about 6 months. There will be more and better quality data coming out later on this year. So until we have a very clear idea exactly what we're dealing with, we should proceed with some caution. I do think that means that while it's safe for kids to return to school, it's prudent for us to follow guidelines. A lot of people come to me and say, well, given that it's low risk for children, why do children need to wear masks? Why do teachers need to wear masks? In other countries with open schools, there aren't any masks worn. And I think what this comes down to is to deal with this, we have to present a united front. It's not possible to respond to a pandemic with everyone following different guidelines or their own ideas. There's been a lot of talk about how Japan has handled or done less badly out of the COVID-19 outbreak than other countries. And honestly, from my perspective, I think one of the best predictors of a good outcome to a pandemic is a communal response, is everyone being able to line up and do the same thing. You cannot form a shield wall if one person wants to stand 10 feet in front and someone else wants to stand 10 feet behind. I think gradual reopening of schools with appropriate precautions in place is also a very good idea, because I know there's some concern. Naturally, within families, there'll be some people who are very, very keen to get back to school with as little restriction as possible, and there'll be other people who are much more nervous. If we don't make a gradual return to school with appropriate precautions and plenty of monitoring, it's quite possible that a significant chunk of people will decide just not to send their kids back at all, and then a lot more children will be left behind, will be left out. So I do think that gradual reopening of schools, appropriate precautions, and everyone following the same set of rules is extremely important here. So that's all I've got to say on the subject. I hope you found it useful and interesting. Please do go and read all of these original articles. They're not difficult to get into, and I've put a full list of references for all of the information that I've used in this study. Finally, at the bottom, there's a very good recent summary article that covers all of the data that I used to make this presentation, and also includes some other information, for example, about children with chronic disease. Thank you very much for your attention, and everyone have a great day. Bye-bye.